Guide for Adult Women 1. My first topic I chose to cover was cervical cancer guideline screenings. So I downloaded the ASCCP app, which I use a lot during practice, and has been very helpful. Some mental notes that I've kind of made to myself is that 21 to 24 is cytology only. Over 25 is typically HPV plus cytology testing every 5 years if everything's been normal. And then primary prevention that we always want to make sure the patients have or is recommended is the HPV vaccine. A lot of patients worry after being diagnosed with HPV, so I found that this was very helpful in one of the articles that we had to read for class that talks about the kind of psychological impact of HPV diagnosis, giving them some handouts, websites, pamphlets, educating that it's very prevalent among sexually active people and there's a low likelihood that it will develop into cancer, and that it's always sexually transmitted. It's difficult to know who exactly they were infected from, and that typically the HPV infection does clear on its own within 2 years. The next topic I chose to cover was contraception. So this table goes through the different types of emergency contraception that's available right now, including Ella, Plan B, combined progesterone and estrogen pills, and then the Paragard or copper IUD. I also have the medical eligibility criteria slides in the next pamphlet in the next slide, and I also downloaded the CDC mobile app for the U.S. medical eligibility criteria. I also attached information regarding IUD and external insertions and removal. This is the summary of the U.S. medical eligibility criteria for contraceptive use. That's the up-to-date one right now. The next area I covered was venous thromboembolism. So I added in some information regarding risk factors for thrombosis, which have to do with like immobilization, prolonged travel, age, previous thromboembolism, pregnancy, different medications, smoking, hypertension, lack of exercise, diabetes, and all that. I kind of just went through also, like, if a patient's coming in with complaints that you think may be a DVT, then low probability we'd want to just get a D-dimer. If positive, then an ultrasound. Medium probability is D-dimer if positive, ultrasound, and then high probability you always just want to do ultrasound. I added in the DVT assessment as well, which includes the Wells score. So it kind of tells you basically what each of these things would rate. Right now it's the most up-to-date and most well-studied guide in determining like their risk of having a DVT and what probability criteria they would fall into. Then I went in to cover hypertension. So the JNC8 guidelines for hypertension kind of just reviews pharmacological treatment that should be initiated when blood pressure is 150 over 90 or higher in adults 60 years or older and 140 over 90 or higher in adults younger than 60. And then with patients that have hypertension and diabetes, it should be initiated if blood pressure is 140 over 90 regardless of their age. Initial hypertension treatment should always include a thiazide diuretic, calcium channel blocker, ACE inhibitor, or ARB in the non-Black community, or a thiazide diuretic or calcium channel blocker in the Black population. If target blood pressure is not reached within 1 month after starting therapy, so important that we do follow up with these patients that it should either be that their medication dose is increased or a second medication is added. Some primary prevention that we always want to counsel patients on his diet, weight loss, exercise, restricting sodium, and reducing alcohol consumption. This is just some information about cholesterol in determining their 10-year cardiovascular disease risk, and how you would start them on a statin. The next topic I covered was amenorrhea. So just kind of some small notes. Primary amenorrhea is absence of menarche by age 15. Secondary, absence of menses for 3 months in people who previously had a period. For a general assessment, you want to do history and physical exam, pelvic, ultrasound, labs, some abnormalities that we could be looking for, congenital abnormalities of the vagina, and disorders of the hypothalamic pituitary ovarian axis. Next, I added in some quick information about Tanner staging of breast development in females because I felt like this was important. And then some chart from Up to Date about secondary amenorrhea and what kind of to order surrounding this. So we want to make sure that they're not pregnant, and that's not why they're having this. If it's negative, the initial exam that we want to do is the history and physical, which I mentioned, an exam, initial lab testing, including FSH, E2, TSH, and PRL, adding a serum, total testosterone if there's evidence of anything that's needed for that. So that's more information on that. Then I went into abnormal uterine bleeding. Some of the causes that we went over with this, so structural causes and non-structural causes, polyps, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory dysfunction, endometrial, AUB, and then not yet classified. So the initial workup for somebody with AUB, we want to get a CBC, blood type and screen, and a pregnancy test. For checking like hemostasis, we need a PTT, PT, activated PTT, and then fibrinogen. Other lab tests to consider, we might want to grab like a TSH, iron, liver function, and some STD testing. The next topic I chose to cover was sexual health and STIs. So typical like sexual health visit, you want to make sure that you're covering the 5 Ps. So partners, if the patient's having sex, what the gender is of their partners, practices, if they are having sex, what kind of sexual contact that they've had, and ensuring that what kind of sex they've had. So if they're having like penis and vagina sex, penis and rectum or anus, so on and so forth. Protection from STIs, so that would include things like condom use, if you're trying to prevent HIV, how they're doing that, if they've had a past history of STIs, ever being diagnosed with an STI, questions about drug use in their partners, and then pregnancy intention. Next, I put in as well the treatment for some common STIs that I felt like I saw a lot this semester. So gonorrhea, chlamydia, syphilis, genital herpes seemed like the most common things that I saw. The next thing I covered was cystitis, which was something I saw a lot this semester as well in clinical. So kind of the risks that I typically asked about was history of UTI, if they've had children, any diabetes, obesity, if they're going through menopause, or if they're pregnant. So acute simple cystitis, we just assume that that's confined to the bladder. There's no symptoms that would suggest that it's kind of traveled elsewhere to the upper tract. So things like frequency, urgency, dysuria, hematuria. And then for a complicated UTI is we're going to see a fever over 99.9. The patient may have chills, rigors, fatigue, flank pain, CVA tenderness, pelvic pain. So some prevention that I discussed a lot with patients this semester is washing the skin around the anus and the genital area, drinking a lot of fluids to flush bacteria out, emptying your bladder as soon as you feel the urge. So every 2 to 3 hours is suggested, and then making sure that they're urinating after sex. And that is all.